So I just want to introduce our speaker for tonight, Dr. Hans Hendriks. He's well known to the rural onboarders. We've got some great presentations from him before. And I see, oh, sorry, that's still the old title. Apologies for that. So we've moved much beyond ortho. This is just top tips for conscious sedation for lots of different procedures in the district hospital setting. And Dr. Hendriks is a family physician with 15 years of experience in rural settings, from Ceres, Western Cape, to Zithulele Hospital in the Transkei, to Upington in the Northern Cape. And he'll have to let us know if something has changed since I've done this little bio CV. And he knows what it's like when the system fails you and your patient have to do and you have to do the best you can with what is available. He's currently also working with the University of Stellenbosch on a diploma in rural health, where he's running the clinical skills module, and he loves to give practical hands-on information, and we're really grateful to have him here. Just a reminder to please add your names and MP numbers in the chat, but there will also be a poll at the end, which is probably the best way to prove your attendance in terms of CPD points. But I am very happy to hand over to Dr. Hendriks now. Oh, let me just get, sorry, apologies. I'm just trying to stop sharing, but my button is not working. There we go.
Thank you, Madeleine, and hi to everyone. So I'll be sharing my screen shortly. I'm quickly going to start just with some theory in the background, you know, just so we all speak about the same thing, what is conscious sedation, and then we'll move on to case studies. I've got 14 case studies. Some of them of the best mistakes I've ever made and learned from, and the patients all survived, luckily. Because we're in rural, we quite often work in ridiculous conditions. We do tend to make mistakes, and if we learn from them, then we just get better. So I'll share some of those with you. And I think it's real practical clinical cases you can use in your district hospitals. Okay, so that being said, let's share screen. Cool. Can everyone see that, Madeleine?
Yes, thank you.
Okay, so procedural sedation and anesthesia, PSA, is what it's actually referred to, same thing as conscious sedation. So the theory behind it is that we use drugs to depress consciousness, but we can never quite know exactly how deeply depressed they are. So the patient can be, let me just get this thing to move. Oh, there suddenly. So you can get minimal sedation and anxiolysis, and then moderate sedation, some analgesia, moving on to dissociative, then deep sedation, and then general anesthesia suddenly, and the patient stops breathing. So obviously there's a whole continuum, and we will never quite be sure because patients react different to medication due to the age, weight, all those variables. And we will never know where our patient is at that stage. So we got to be careful. I used all the data. Sorry, this is slow to react. All this information, I also use the SASA Guidelines for the safe use of procedural sedation and analgesia for diagnostic and therapeutic procedures in adults. It's online available. Really worthwhile reading through, very thorough. Okay, so the next question will be, where in our hospital or CHC or wherever you work will we do procedural anesthesia? And the answer is quite simply, and I think in the government setting at least, any district hospital definitely has two places where you can do this: in theatre or in your resuscitation area in your hospital. So this is a picture of Upington, the Dr. Arisuti Hospital where I work. One of our two resuscitation beds in casualty. You see the red trolley, all the monitors. We've got everything to manage the airway immediately available. So any conscious sedation procedures we do, whether it be for orthopedics or anything else, we do in these beds, either here or in theatre. And the reason is, like I said, it's unpredictable. We have to be able to get our hands on oxygen, assistance. management of the airway, and you know, all the other things. And these are the only two places it's usually available in a hospital. So stick to that. If we start doing it say we do it in general ward and we decide to sedate the patient and he stops breathing, it usually takes too long to get everything together to intubate or ventilate, and that could be big problems. Just thinking back of the anesthesia launchpad mantra, I think it's a course that was done by the UCT team last year in I think in East London. But they've got 5 steps. Prepare as well as you can. In other words, all your monitors are there. You've got a drip. You've got emergency drugs available, oxygen and an oxygen mask already ready to use. Then you pause and you'll just ask yourself, where am I now? Have I got everything ready? Is the people I need to assist me around? All those things. Do the basics right. And I think I want to almost add to it, do it the same way every time, because then you get into the pattern and you immediately miss when you skip a step. Expect and manage common and severe complications, of which airway is probably the most common one. And value the recovery period. We very goal-focused people, doctors in general. Like as soon as that arm is reduced and the pop is applied, we're done with the patient. But meantime, the anesthetic is still on board and they could still stop breathing. So the recovery period is definitely a danger area, and we must always take our time with that. Okay, there we go. Safety tips. So these are some of the tips I just want to share that I learned for myself. Work with what you know. So some hospitals where I work in the Northern Cape, some of the CHCs and district hospitals have only propofol, some have only ketamine, some have other drugs available. But whatever you have available, use it and use it consistently and the same way. And then you will just immediately start noticing if the patient reacts differently because you're used to the way the drug works. So pick your drugs and stick to them. I would suggest avoiding polypharmacy. If you're an anesthetist and a professional and you do this often, you're welcome to mix and match. But if you use a propofol, midazolam, you add a spot of morphine, a bit of ketamine, the patients, will react very differently, and they might be way deeper than you'd suspect, just because people react differently, and now you've got 4 drugs on board. So rather stick to 1, 2 at the most drugs. Remember the informed consent. Like I said, we're so goal-driven, we want to get going, and we forget to get the signature that there's consent for the procedure. Titration is one way of taking the guessing out of how much to give. So especially propofol is a drug that titrates beautifully. Just give it slowly until the desired depth of anesthesia is reached, and then you can stop there without over-administrating. And then lastly, always have an IV line available. Always. So never do any form of anesthesia, even things like brachial blocks. Don't do them without a drip available. So these are the causes of common adverse events according to SASA. That's not the social service, it's the South African Society for Anesthetics. So they say quite commonly it's an untrained practitioner or inexperienced and inappropriate patient selection. So to give an example, I'm thinking back of one of my early days when I was a young doctor working in Worcester Hospital Casualty in those days. There was a very morbidly obese lady with a shoulder dislocation, and I reduced it. Those days we used pethidine and dormicum. I had to use quite a bit of it because she was very big, and suddenly she stopped breathing. Luckily, after I got the shoulder back, but then I had to support the airway and, some bagger and jaw thrust and everything. It took quite a while for her to wake up enough to manage her own breathing. So that was an example of an inexperienced practitioner, and my patient selection was probably not the best. Procedures not suitable for the sedation. So if it's very painful procedures, you might consider different drugs. Or if there's already drugs on board, you might consider using others or less of certain. And then also combination drugs, like I said, polypharmacy becomes dangerous sometimes. Administer the drugs, the timing for it is important. So the timing in terms of when the patient has last eaten, when the alcohol was last used, also in the 24-hour cycle of a hospital, 2 o'clock or 3 o'clock in the morning is probably not the safest time, and you might change your mind and wait a little bit. Inadequate monitoring of the patient. So absolutely essential. It's done in the resuscitation area where you've got all the monitoring, blood pressure sats and heart rate at least available. The inability of the practitioner to manage complications. You must be comfortable intubating a patient, I think, at least, and managing the airway that way before you can do this. Quite often the patient end up in a deeper than intended level of sedation, and then you might just either support the airway a little bit, or you might decide to convert and intubate and ventilate. Premature discharge. There's some horror stories of discharging a patient and then the child falls asleep in the back of the car and stops breathing. So the patient, you have to be sure that the patient is wide awake before discharge. And then poor communication, like in everything in life, between patient and doctor, between the sedationist and the surgeon, can often lead to problems. So the red flags, quite simply put, is older patients. So older than 65, expect them to be more fragile, more reactive to the drug you give. So if you give propofol, the blood pressure is going to drop more than it will for a 20-year-old. For instance, the drug abusers, they will probably need more of the drug. So if you titrate, you're probably going to end up with high doses. Obesity, airways are always a problem, like pregnant patients. You might think airway. Pediatric patients is a red flag just because they're pediatric patients and small, but I find them to be the most patients that actually react the way I expect. I usually use just ketamine for them, and they usually react very well. They fall asleep when they should, they sleep as well as they should, and they wake up when they should. I've just found them the easier patients to work with. And then the last two is acute ethanol intoxication. You'll need less propofol. Where chronic ethanol patient that's not intoxicated at the time will probably need more propofol. And we've all seen that 2 ampoules of propofol for one patient is quite scary. And then you talk about conscious sedation. As soon as I get the next slide. Okay, rules on fasting is about the same as general anesthesia. Clear fluids you would prefer to, like apple juice and water, at least 2 hours, or solid foods 6 hours before you start with conscious sedation. This is ideal because, like I say, you never know if the patient becomes deep and you have to intubate, and then you don't want to do that on a full stomach. So it's ideal to stick to the fasting rules. Now I'm just going to go through 3 slides of the common drugs we use in conscious sedation and just some tips on them. So midazolam, or midaz as the EMS personnel like to say, is a very nice short-acting benzo. It's important to remember it's got no analgesic effect. And in 15% of cases, it will develop a paradoxical hyperexcitement. So the patient will be more awake and more excitable than the other way around. I've only seen this in children, but it's quite a surprise when the opposite from what you expect happens. There's always a risk of respiratory depression, especially when the patient is intoxicated. The dose is 0.05 to 0.1 milligram per kilogram IVI with a max of 3 milligrams, which makes it really interesting since the midazolam comes in a 15 milligram ampoule. The ones we have in Upington is always a 15 milligram. It's like they want you to use more. So don't fall for it. They're going to stop breathing. 3 milligram is the max dose initially. You might decide later on to add on titrate, but never go for initial dose more than 3. Propofol as my second drug is a lovely drug to work with. But to remember that it's got no analgesic effect. It doesn't stop pain. So if you're doing a very painful procedure, like a dislocated, fractured ankle, for instance, you will not only get away with propofol, you've got to add something for the analgesia. It titrates very well, and you can titrate it beautifully to effect, since it works so quickly. It's one arm-brain circulation, and it's seconds, and it's basically working. It's a painful injection. It burns a little bit. So to add some IV lignocaine, not the ones you use for local anesthesia, the IV lignocaine, you just add a ml or two of that to the propofol, and it takes away the burning sensation. Sometimes hospitals buy the 50 milliliters ampules of propofol. And then people tend to use it, they keep it in a central space, and everybody, as you use it, you go draw out some more. But there's a risk of after 24 hours that it becomes contaminated. It's actually a very good growth medium, and you should dispose the ampules after 24 hours. Always do that. If you inject it fast, the blood pressure drops and the patient stops breathing. So remember that, and that's another good reason to titrate slowly, especially the propofol, especially in older patients. Otherwise, that blood pressure can scare you, and the breathing will stop. The conscious sedation dose for propofol is 0.5 to 1 milligram per kilogram. If you think back, induction dose you will use for general anesthesia is 2 milligram per kilogram. So this is way less, but a lovely drug to use. Which brings us to ketamine, which is like the greatest drug ever in our context in rural hospitals. Yeah, it's saved me so many times. It's a very strong analgesic, a very strong sedative. It's actually also a very strong bronchodilator. So, in your severe bronchospasms, this is another one to use. It's an all-in-one drug in that sense. You can give it IV, per os, intramuscular, per rectal, sublingual, and nasal for kids. Works beautifully. To remember that it does increase secretions. So a lot of pediatricians use, or doctors that work with this, with the pediatric patients, they just add some atropine to the drip. Then it takes away the secretions. It can become quite bothersome in our peds patients because of the smaller airways. In adults, it can, if you use it on its own, cause quite a delirium, and the patients can go totally bonkers if you use only this and not enough. So it's safe always to add a benzo, like say 1 milligram of midazolam, just to take away that delirium part for the patient while it's on board. Remember that ketamine comes in two ampules, a 10 milligram per ml and a 100 milligram per ml. So to be careful, I've once given the 100 milligram where I asked for the 10 milligram. So if you ask the sister for the ketamine, they draw it up. Rather look for yourself. Which ampule did they use? And even draw it up yourself so that you are sure you're using the right one. In that case, the kid got obviously 10 times the dose, and he just slept a bit longer with no side effects. I monitored him very well. But it's that safer drug. It doesn't drop the blood pressure so much, if at all, and the respiratory reflex stays intact beautifully. There's a lot of tachyphylaxis that happens really quickly after repeated use. I've seen this in kids with burn wounds, where we use ketamine to basically take the pain away, keep them sedated to clean the wounds. Even by the third time we use it, we almost double the dose. So don't be scared of upping the dose, but just know that you're not going to give 1 milligram per kilogram with repeated use. The doses are going to go up and up and up as they adapt. So the per os or intramuscular, per rectal, or nasal dose is 5 milligram per kilogram, up to 8 milligram per kilogram even. So it's probably a little bit higher than that. IV is 1 milligram per kilogram, and just as a reminder, the induction dose, if you should use it in theater, will be 2 milligram per kilogram. So yeah, lovely drug to use. Which brings us then to Ketafor, which is a combination of propofol and ketamine. I think this is more used by people that do anesthetics on a daily basis, do a lot of conscious sedations. They've got TIVA lines and infusion drivers, and they know how to mix it. They know at what rate to run it for what weight. It works very well, I'm told, and the couple of times I've used these two together, I've had great results. So I think this is really the way forward in the future, when we've got total intravenous syringe drivers that can do it for you, then it's actually a lovely way to just keep the patient sedated, and as soon as you stop, they almost immediately wake up. There's two mixtures. For infusions, it's a 10-to-1 propofol to ketamine, and for the bolus, they use 1-to-1 propofol and ketamine dose, 1 milligram to 1 milligram combinations. Which brings us to morphine. So morphine is an add-on for when you want to manage pain. Use it IV, avoid intramuscular, because intramuscular is just erratic absorption. It's quite painful sometimes to inject, and sometimes they get a very strong effect, sometimes no effect whatsoever. So morphine, I only use IV, and I titrate to need. It takes quite a while to kick in. So don't expect, as you inject it, like propofol, the pain goes away immediately. It sometimes takes up to 20 minutes. It's a little bit of a slow drug. So I quite often give this, prepare everything, and then start with the rest of the procedure a little bit later. And then also the risk of respiratory depression, especially if the patient is intoxicated or there's other drugs on board already. And the last drugs that we find in government setting is etomidate, fentanyl, and pefalgan, the IV paracetamol, also lovely drugs to use. Obviously, none of them on their own. Like the IV paracetamol is a lovely analgesic. If you would want to use it, say, together with propofol or something that's got no analgesic effect, it works very well. That's the last of my theory, and this takes me straight into our case discussion. So in red, you'll see a link. It's a very, very nice YouTube link to talks that Dr. Dave Bishop, he was previously, as a young doctor, he worked in Zithulele in the Transkei, so he knows the district hospital setting and the realities thereof. And he developed these YouTube talks on conscious sedation techniques for different scenarios. So it's as much as what I'm going to do now with case discussion, but just in more detail with more explanation. So if you want to know more about it, click on that YouTube link and go have a look at what he shows you. Very, very well described and well explained. So I'm going to go through 14 cases now, and it sounds like a lot, but it's quick. And I think they all cases that I've at some stage, okay, Ceres have never been one of my patients, but like similar patients. And it's all cases that I've managed in the hospital and, made mistakes with or did something really smart with. And I'll share that with you. So the first case is the classic example of a 23-year-old rugby player that presents with a shoulder dislocation. He weighs 120 kilograms. He's got lots of muscles. That shoulder is already cold after the game, so the muscles are shortened and tight, and this is going to be difficult to reduce. So what drug will you use? And I'm going to share some of my examples. So in the old days when I was a young doctor, we would give Betadine and some benzo. That does not work well. I just remember fighting to get that shoulder back and quite often having to go and up and up and up the dose to the point where the patient stops breathing, as my previous example. So these days, the last 20 years, I've only been using, went too far ahead. Sorry, slides are slow to react. I'm going to leave it here. So my options is propofol. I always use propofol. And to use 0.5 to 1 milligram per kilogram, which works out that way to something between 6 and 12 ml of propofol to use, which isn't a lot. So in a rugby player like that, I would put up a drip. I will explain. I'll get my mates that's going to help me pull the arm, whichever technique I use. I prefer the Kochler method, and then I would slowly start giving the propofol. Usually the patients becomes very talkative in a slurred voice kind of way. And then at some stage, I see when I move the arm, they don't fight me anymore. And that's usually where I stop that slow injection and then reduce the arm very easily. Another option is to give ketamine 1 milligram per kilogram with benzos. And I know a lot of people use this because they don't have propofol available in the CHCs. I actually think if you want to use ketamine, just a spot of ketamine, like 25 milligram for a big guy like this is a very low dose. It's like 0.2, 0.3 mol per kilo. So a little bit of ketamine for the analgesic effect, and then you titrate the propofol. Then the pain is also very well managed. Second example is a 23-year-old lady. She's HIV positive. It's not the person in the picture. This is just off the Google. So she was HIV positive, and she was very wasted with a weight of 40 kilograms and a history of 3 times previous mandibular dislocations. She was at the Postmansberg Hospital, and I was visiting there when they asked me to help them reduce because they can't get the jaw back. So I had to sit up with the back against the wall, the way I usually reduce, and with a drip, I slowly gave the propofol, 0.5 milli. I used a very low dose and slowly titrated because I knew it was a small woman. And then with the technique, how you reduce the jaw with my thumbs on the back molars and you know, my pinky kind of like under the maneuver, you know, under the mandible. I just manipulated it back very nicely. So propofol also my go-to drug, but ketamine with a benzo will probably work just as well. Just ketamine makes them tense, the muscle tense. You know, the muscle tone is a little bit higher sometimes, and you fight a little bit more with the muscles. That's why I like propofol so much. Okay, so next case is a 65-year-old woman that presented with a displaced Colles fracture. She fell 5 hours, you know, before she saw me. So this brings us to the options of local techniques. We don't have to always go for conscious sedation. So I love, in this case, using a hematoma block. I'm just trying to get my screen. There we go. I'm going to leave all of them open now. Sorry, I'm just struggling to get the PowerPoint to work with me. So a hematoma block is lovely. If you've got a nice fresh fracture, especially Colles fracture, you can see that bump of the hematoma. And then I use 10 to 15 mils of lignocaine. The lignocaine you would use to suture skin lacerations, for instance, and I inject it right into that hematoma block. It works so well. I've been astounded many times. So this is, I think, an ideal patient, because then you avoid all the systemic sequelae of anesthetic drugs. Another option is brachial blocks. I love brachial blocks too, or even a Beers block to reduce it. But I mean, there's some skill set there involved. So I know a lot of people prefer to do it under conscious sedation. So in her case, I would probably also use propofol, because it's quick in and quick out, and the patient can go home soon after. But to remember, she's 65, so go slow and use a low dose there. Ketamine with a benzo would probably be also fine. So for instance, if you use ketamine 25 milligrams just for pain, and then slowly give even less than 0.5 milligram per kilogram propofol will probably be enough, so that you can just manipulate that distal fragment back into place. My fourth case is a 35-year-old woman with a Weber B3 fracture. She was very obese, 135 kilograms. So this is a good example of, it's a very painful fracture. And if you start manipulating that fracture to reduce the ankle and get the bones back into place, propofol on its own will not do it. They're going to fight you, even if you go full induction doses. So something else needs to go on board. So ketamine is an option. I usually give her morphine. It's funny enough, there's exactly this patient now waiting for me in casualty. I'm on call for orthopedics. So I'm going to do this now. And I would walk in and I will first give her some morphine, 5 milligrams. So that's my analgesia. And then I'll probably titrate the propofol and just manipulate the ankle into place. Ketamine is a great option also, but just to remember, with a big patient like this, airway is always a problem. So probably manage the patient in Trendelenburg with a head up, not flat down, and then just go really slow with the propofol. You don't want to stop breathing. Then kids, like I said, I love ketamine in kids. They're just so predictable to some extent. So this is a classic example, an 8-year-old boy with a Gartland 2 supracondylar fracture that needs a reduction. I used to, in my younger days, when I started using ketamine, I always gave it intramuscular. I reckoned, like, they're going to get one injection. I can just as well give it in, intramuscular. But there's definitely a more erratic absorption. It takes longer before it works. sometimes it just doesn't work. And it seems to me sometimes that since it's painful when you inject it, the kids start screaming or crying. They keep on screaming and crying the whole time. So these days, I always put up a drip and I give the ketamine intravascular, 1 milligram per kilogram, is easy to calculate. And then I give it IV, they sleep, reduce, I pop, and when they wake up, usually it's so quick that by the time I've done the pop, I've written my notes, they're awake enough so I can walk with them to x-rays and do the post-op x-ray. Okay, now I'm just trying to get, there we go. I need some words as well, I guess. Okay, so a 3-year-old girl presents with hot water burns to the whole of her abdomen. She weighs about 10 kilograms. Now, this is a classic example of something we see a lot. And there's nothing that is so terrible to see as, the sisters grabbing this patient and starting to wash the burns wounds with the child screaming. That's permanent psychological damage we do there. So never manage this without good analgesia. And a recipe I learned when I worked in the Eastern Cape was ketamine, 5 milligram per kilogram, midazolam, 0.1 to 0.25 milligram per kilogram, plus paracetamol, everything per os. So what you do is you take a syringe, you draw up ketamine, you inject it into another syringe. You draw up your midazolam, works out at 1 to 2. In this case, it would be 1 to 2.5 milligram of midazolam. You draw it up, you inject it to the first ampule, and then you take, syringe, and you take that syringe and you draw up your normal oral paracetamol, that nice green syrup, 10 to 20 milligram per kilogram, or 5 mils is fine. And then that mixture you give to the child to take orally. And then they slowly fall asleep, calmly, as the pain go away. I go see 1 or 2 or 3 other patients, and when I come back, she's nicely sleeping, obviously on monitor. And then you can do a very good dressing without, psychological damage. And usually at that stage, we wash off all the blisters, get it nice and clean, and get all your dressing on and wrapped. Now, this is also a good example. If this patient is now admitted to the ward with multiple days and multiple dressings, the same dose of ketamine will not work. You'll probably, by the 3rd dose, double that ketamine to 10 milligram per kilogram. But yet again, titrate. So see how she reacts, give her a bit more. See how she reacts, give her a bit more. But please never manage these things without very good analgesia. My 7th case is one of our very good local dentists helped me. It's a patient that was referred from Springbok to Upington. He was a intellectually impaired young man, but his teeth was in a terrible condition. So they had to, we had to pull the teeth basically. And he was not a good candidate for general anesthesia. And as it was, our theater was busy, and he was just that day here in Upington. So I asked the dentist, he came over. And what we did is we put him in casualty. In that picture I showed you of our casualty bed, he was lying there. We put up a drip. I gave him 25 milligram ketamine bolus, and then slowly titrated propofol 5 milliliters initially. And then he was asleep, and the dentist started giving his blocks and started pulling the teeth. This is not a picture of the case. He was actually, all the teeth almost got pulled. I added 2 more boluses of 2 mils at the time propofol. In total, we used for that young man, we used 9 mils of propofol. He slept through it beautifully and woke up beautifully. No fighting, no pain, and job well done. And we could very well manage the oral space and the airway throughout. So I think this is an example of how ketamine and propofol works just beautifully together. And this is definitely my go-to drug in the future when we've got similar cases. So that's, I think, very nice one for dental extractions and conscious sedation in the dental field. The 8th case is also one of my mistakes I've made in my life. 72-year-old man that presented to casualty after he was attacked by his neighbor's dogs. Both his forearms were ripped open with radial ulnar fractures. His ear was ripped off on the one side. And as he came in, he was in a lot of pain. The sister immediately gave him morphine, 5 milligram IVI. And because the casualty was chaos, and I was running around with many other emergencies, I asked the sister in charge, just please give him, and I worked out 70 milligram of ketamine, please give it IV stat for him. And basically the nurse drew it up, went over, and boom, gave it stat IV immediately, flush. And that together with the morphine, he slowly just stopped breathing. So I had to really jump and bag him a little bit and just, manipulate the jaw a little bit, jaw thrust. And then he started breathing again, and we could continue with a very thorough washout and cleaning and the POPs and everything. I think yet again, my take-home message, and I will not make the mistake again, is draw up the ketamine yourself and maybe inject it yourself and give it slowly, kind of titrate. Morphine usually, ketamine usually we calculate the dose and we give the dose. But in a patient like this that's already had morphine, go for half the dose initially, see how he responds, and go give the second half, for instance, and give it slowly. Otherwise, he might stop breathing on you, and there's a run around to get everything ready. Okay. So the ninth case is a 51-year-old woman. I didn't even put a picture here. It was so terrible. Her husband tried to chop her arms off with a panga. They were both drunk. He was more drunk than her. Obviously impaired state of mind there. So she had multiple cuts on her arms with multiple fractures in both arms, radial ulnar. And the patient, she was herself a little bit intoxicated, but obviously a terrible, now you've got to do a washout here, and you've got to suture the wound, you've got to stop the bleeding, you've got to put back slabs on. So very complex case, but turned out in the end went so easily and so well. And I think what we did best was we got the entire casualty team there, and we prepped everything, all the pops, all the water for irrigation was ready. She had a good line. We gave the initial dose of ketamine, and then we gave a little bit of morphine as well. I didn't want to give propofol because of her alcohol use and everything there, so I just stuck to those two. And pain relief was the main thing for me. And then we started washing out. And as soon as she starts having pain again, we gave a little bit more ketamine, a little bit morphine. We probably ended up on triple the doses. And she was, lovely conscious sedation all the way through and didn't stop breathing when we were done. And she was, had obviously less pain manipulating the arms. But we did a thorough washout. We sutured the skin. We put up back slabs for both arms. She was subsequently operated, and I saw it 2 months later with relatively functional arms. So yeah, I think that was a very good lesson for myself, how you can give a dose and add up on, titrate upwards, even above expected doses. Like I said, in the acutely intoxicated, you're going to use but sometimes way less, but then with a lot of pain, you might end up with high doses. So, but it was done in casualty, in the resuscitation bed, so we could convert, the airway as if needed in any case. The 10th case is a classic example, a 31-year-old man that arrives at 1 o'clock on a Sunday morning with an open fracture of his right tibia, Castello 2, so it's a biggish wound, and is very intoxicated. Now, I think first thing to say is this the best time to do the procedure? 1 o'clock, between 1 and 3 is not a good time in a hospital in my mind. And I would probably delay any, bigger procedures and phoning people to theater and things like that. So in this case, I would just give him his IV cefazolin, because we know the sooner we get that with open fractures, the better. I will do local block and a good washout that we can do with, water for irrigation, and just get it nice and clean, even suture the wound, and delay the official debridement and all those things for main theater can be done during working hours the next day. So pick your battles. Avoid 1 o'clock to 3 o'clock in a hospital. My 11th and 12th case, you'll see it's almost exactly the same, but my point is that I want to make is the difference in the patient. So the first one is a 14-year-old girl that presents with an incomplete miscarriage around 10 weeks, and she needs an evac. Now, I know in some hospitals they give just Voltaren, and some they give Voltaren and a spot of pethidine. I actually find it very insufficient, but be that as it may, I love taking this patient in a district hospital context. I always go to theatre, since everything I need for a thorough evac is there, usually. And then I love giving them 2 milligrams of Ativan, and then start with 5 milligrams IV morphine, and I can go upwards. And usually with these young girls, they're very anxious. This is very new to them. It's a shock. It's painful. You know, they're very uncomfortable, and I tend to give more and more morphine as needed. The Ativan, the benzo, has got an antegrade amnesia, so it's lovely. Then they don't remember this terrible experience as vividly, or maybe not at all, which is ideal. Where in the example number 12, the 35-year-old lady, grab 4 para 3 with early incomplete miscarriage, they'll probably be quite comfortable lying, getting evac with almost nothing. But I go for the Ativan, and manage your patient. I probably use less morphine. It's an analgesic, so it need to be there, but 2 to 5 milligram. And if the patient still feel pain, I will give a little bit more. So yeah, use it for specific patients. Then my second last slide is in last 2 cases this is a classic example. 80-year-old man that comes into casualty with a paraphimosis for reduction. So yes, everybody knows we give a penile block and then we reduce it. There's tricks with sugar water, which I find very slow in working. I'm usually in a bit of a hurry, so I want to get this fixed and go to the next patient. So penile block is very effective. But what we forget is a penile block is for the foreskin. It's a superficial block. So you actually don't block the glands, which is a very swollen, very painful one that's getting, all the fluid forced out of it. So we're not actually giving very good analgesia. And then yet again, a 16 to 26-year-old man usually is the biggest sissies in my mind. They don't like pain whatsoever and they can't take it. So I always give morphine as well, 5 to 10 milligram, even add ketamine with the penile block, and then you can quickly do your reduction. You can even give a little bit of local for a dorsal incision if need be, those kind of things. Everything's more manageable for them when there's morphine on board. But remember that a penile block on its own is usually not enough. You need a little bit more. And then my last example is a 5-year-old boy that presents a casualty with a mid-shoulder femur fracture after being run over by a car. And this is a classic example, a child coming in with a femur fracture. That's terribly painful. The parents are also in a shocked state. And now every time you move that child, you put on the skin traction or whatever, move them from one bed to the next, they scream and the parents are, very agitated. It's so unnecessary. So what I usually do for this child, I put up a drip, I give some ketamine, they fall asleep, and there's no pain while I put up the traction. I move them from a stretcher to the bed, from the casualty to the ward, and by the time they wake up, they've been lying still, the muscles are more relaxed, and the traction's been effective, and the pain is almost zero. So I think this is also a very nice way of using conscious sedation. That is the end of my story, and I am now open for questions.
Oh, thank you very much, Hans. That was awesome. Can you open the Q&A there? It might be easier for you just to read the questions yourself. And there's a couple of questions in the Q&A. So for people who would like to ask questions, please put them in the question and answer section.
So lovely.
Yeah.
Oh, this is a good question. So evac for incomplete miscarriage, is it advisable to do a lignocaine injection for cervix or cervical block? Yes, it's very worthwhile doing. I must be honest, I've always found that the injection is more painful than the benefit it gives. It's totally anecdotal, kind of like when I inject, the patient is usually so uncomfortable that I almost want to avoid it. But in theory, yes, a good thing to do. And it's very easy and quick, especially if you've got those dental syringes with a very fine needles. Does purfalgan have sedative effect, or just an analgesic? It's only an analgesic, and it's got a limited effect for pain with trauma. So I know I've got a friend that she had a cesarean section and they gave her pethidine afterwards. She said it didn't work for her, but the purfalgan was absolutely wonderful. She could even feel it running in. So it seems that some people it works very well. Some people it doesn't. I don't use it a lot in the casualty setting, but it's actually now readily available in government hospitals. If you don't have it, you can actually order it. Yeah, I think it's a good option as analgesic, but there's no sedation involved there. Those are the two questions that I see on the Q&As. Is there anything
Sorry,
else?
Hans, I got distracted by the poll that I've just launched. Did you answer the question
Yes.
about the lidocaine and the cervix?
Yes, I did.
Thanks. Excellent. Yeah, just people are also welcome to put their hands up if they've got any other questions or questions they want to add to the chat. I think what was striking is it was a very practical presentation, so we might not have loads of questions because I think you've covered such a wide range of scenarios. And I think it is, I liked your thing of get your particular little sort of set of how you do it and get used to doing the same thing again and again. So it is all about practice and building confidence. And there's another question that's just popped up.
Okay, so Dr. Govender, I recently did a reduction on the ketamine IMI using 5 milligram per kilogram. As I could not get a drip, it took 2 hours to regain consciousness. So that's exactly my point. Yeah, that's why I stopped using IMI. It's erratic and they sleep very long. It doesn't have to be scary. It's actually very nice sleep for the patient, and the airway is very well protected with ketamine in general. And if you're in casualty where you've got him on a monitor, usually from where I sit and write my notes in the casualty, we can see the monitor, all the time. You kind of keep an eye, but it takes a long time for these kids to wake up. So that's why I rather go for IV. It's actually, it works out so quickly that I have everything ready before I inject it intravenous. So yeah, in my mind, that's a way to go. And then
Hans, maybe comment on the use of ketamine IMI versus oral. So if you can't get a line in and you're struggling to get a line in because you've got all these other preparations, and I like your burn wounds case. So just a little bit of a talk about oral ketamine.
Yes, so in those cases, I use IMI. I've recently used IMI as well, but usually for less serious cases, just where I want to do a LP in bloods and, basically admit a kid. Or, and like my example of burns wounds, I prefer to use the oral ones because those kids are already traumatized plus. So, put up a drip and all those things, injections, just give the oral and it works very nicely. Dr. Hartwing said, thank you. I would like to ask, does midazolam wear off before ketamine when given orally? I actually don't know. I'll have to look at the half-life for oral use of it, but I wouldn't even know if the midas, because both make you sleep very nicely. So I'm not sure there. I just from what we used, the formula we got, and I think it's actually was described that formula in the Natal burn units, that composition of midazolam, ketamine, and paracetamol works very nice. There's a question, will the presentation be available? As I understand, it will be on YouTube.
Yes, so it'll be on the Radasa YouTube channel will have the recording. Definitely. And then maybe if you send me, I'll remind you via WhatsApp, Hans, the name of that book, the conscious sedation book that we can get online. Then we will add that to the resource tools that we will send out tomorrow as well.
Yeah, it's on the second slide.
Okay, yeah. I'll look up it as well.
There's
That's
a question
great.
here from one of our doctors saying, will you always report a 14 to 15-year-old pregnant woman to SAPS? In theory, yes, you will, but you will not as a doctor necessarily report straight to SAPS. You just have to notify your social worker, and they usually, in the way the government setting is usually set up, refer them to the social worker, and then you've done your part. They usually have a system how they report to SAPS, and the thing, you know, the whole process go forward. But definitely we always have to report them. There's a question on mixing of Activan and morphine. Yes, it works. It will actually work very well. It's very close to the pethidine diazepam, kind of like that we used in the old days. It's an opiate and a benzo, and there's not a lot of sedation and not a lot of analgesia there for me usually. So I don't use that specific combination, but it's legit. You can use it, but you'll probably have to go to quite high doses if it's a painful procedure, and then they're gonna stop breathing afterwards possibly. In the case of doing a MVA for a ICA, what is your recommendations? So I guess this is a manual vacuum aspiration for an incomplete abortion. So I'm just working through this. What's your recommended sedation? And this is where I love using actually Ativan or midazolam. So just sedation with morphine is actually my go-to. The previous one that I say I never use, I actually use this for MVA. It's not very painful procedure. So that's why, you know, the morphine, and then with the benzo for the amnesia effect, and then, you know, just don't give the injection and think you're going to start doing the evac absolutely immediately. The morphine takes a little bit of time to kick in. So give it 5 minutes and then start working. Next question is, what use in case of caudal block, in case of backache? So this is not, you know, this is a very technical block. Our anesthetists do it quite often. Pain clinics, you might be skilled in it. It's very effective. I've never done it actually myself, but I've seen it done. Very good one for especially the chronic backaches. So here's 2 questions for the hematoma block. Will you use that or also sedate the patient? So yeah, the hematoma block works within 5 minutes and on its own. I've literally had a 20-year-old man with a Colles fracture that was very displaced. I did the block and he held his own arm for me while I reduced it and put on the POP. And I mean, for a 20-year-old man to sit and watch that, there must be absolutely no pain. So I'm very impressed with hematoma blocks, but I want to stress that usually like day 2, day 3 after the fracture, the hematoma has been almost reabsorbed and you don't quite get the block that spot on. So in acute block, definitely, and it works very quickly. I'll give it, if it doesn't work by 10 minutes, then you probably missed the spot and you don't have to sedate the patient as well. And then did I understand correctly? Can we give IV ketamine orally, but as 5 milligram per kilogram? That's correct. So the oral dose, the rectal dose, the sublingual dose, the nasal dose is 5 milligram per kilogram. IV obviously way less, 1 milligram. Then for an MVA, is it wrong to use pethidine 100 milligram IVI with diazepam? That's totally legit. I actually know most hospitals use this combination, and I think it's fair. Especially when you've got like an outpatient set up for your manual vacuum aspirations, that's way better than nothing. I think personally, I just think only giving Voltaren and nothing else is really, that's harsh. I don't think that's more torture than anything else. Next question is midazolam 3 milligram. You spoke about earlier as. Is it per kilogram max dose 3 milligram or total max dose? It's a total max dose for adults is described as 3 milligram. That being said, if I use it for sedation for, say, psychiatric patient, I would start with a 3 milligram, but then I will add on. Like I say, the ampoules come in 15 milligrams, so there's lots of it. But then you give multiple doses over time, not 15 milligrams stat. They're definitely going to stop breathing with that. So that's a theoretical total max dose. Can I give IV ketamine be given orally? It's the same preparate. Ketamine comes only as one preparation, and you can use that specific one. You can use IV, oral, rectal, nasal, sublingual, you name it, you can use it. Same drug. Patient developing hypertension after using ketamine. I have seen this once or twice where the blood pressure goes up quite a bit, but it's not like for permanent. I think it's because ketamine actually doesn't drop your blood pressure like most anesthetic drugs do. So if they've got high blood pressure, they've got pain, and now you give them ketamine, and obviously they've forgotten to take the oral antihypertensives that morning, the blood pressure might go really high. I will not necessarily react to that. I will first just wake them up and see where you are then before I react to it. Remifentanil as probably midazolam, more predictable, can also use as infusion. I don't know remifentanil. From what I theoretically remember, it's a very fast-acting, short-acting fentanyl. It's probably, yet again, if you know this drug and you use it regularly, especially if used in theater, then you can probably predict it and use it much more safely. If I get this drug now and I'm going to use it on my patient that I'm going to reduce the ankle for now, it's probably not as safe in my hands. But I don't know those. If it's available in your hospital, get to know it and get to know the context in which you use it. It will be safest. Sorry, I think the first question was asking if could pethidine substitute morphine? Yes, pethidine can substitute morphine. Morphine is supposedly have more nausea and vomiting than pethidine. I think South Africa is one of 2 countries in the world that still use pethidine. It's actually taken off code in most countries in the world. So I don't know how long we're going to still have pethidine available. But it is used either or, not both of them. And I think that's the last question.
Oh, wow. Hey, it's lovely. It's always the devil is in the detail, as they say.
Yes, it is.
And I think that's what's very practical and has really helped people to maximize what they've got in their own facilities. Huge thank you, Hans. We're exactly on time. We've had exactly an hour. So I think people need to get back to their families and their evenings. Very much appreciated. We will be in touch again for some future webinars, always very practical and very helpful for our rural settings. So thank you very much. If you are able to complete the poll, please do complete the poll. If you're not able to complete the poll, please make sure your name and MP number is in the chat. Thank you very much. And thanks very much, Hans. Have a lovely evening.
Yeah. Thank you very much and have a good night, everyone.